Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, students, and welcome to Crazy Nurse RN Hub, where learning becomes a tradition. My name is Crisel Merducanes, nurse educator, teaching medical and surgical nursing. For today's topic, we have gas exchange and respiratory function. This is part of your oxygenation topic. Let's start. So this is your respiratory system. I believe that you have already discussed this during your anatomy and physiology class when you were in first year. Let's have an assessment of the respiratory function. Expert assessment skills must be developed and used to provide the best care for patients with acute and chronic respiratory problems. So it can be done in two ways. First, we have to understand the respiratory function. Second, we have to determine the significance of abnormal diagnostic test results. So expect that on this topic, we'll be discussing the anatomy and physiology of your respiratory system, as well as the significant diagnostic tests that would serve as our assessment tools in determining our patient's condition in terms of their respiratory system. Now let's have the anatomic and physiologic overview. So your respiratory system is composed of two tracts, which are responsible for ventilation. First, we have your upper respiratory tract. It is also known as your upper airway, and it warms and filters the inspired air. We also have your lower respiratory tract. It is also known as your lower airway, and it accomplishes gas exchange or diffusion in the lungs. Okay? So the main function of your upper respiratory tract is basically the entrance and exit of your air. Okay? However, in your lower respiratory tract, the main function of this is more on your gas exchange, okay, that is happening inside the lungs. Now let's have your upper respiratory tract. It consists of nose, paranasal sinuses, pharynx, tonsils, and adenoids. We also have your larynx and trachea. Let's discuss about the nose. It serves as a passageway for air to pass to and from the lungs, and it filters impurities, humidifies, and warms the air as it is inhaled. For your paranasal sinuses, it serves as resonating chamber of speech, and it is a common site of infection because these air spaces are connected by a series of ducts that drain into the nasal cavity. That is why it is prone to develop infection. We also have different locations of your sinuses. So I have here a picture that will serve as your guide on the different locations of your sinuses. So to name those sinuses or the location of your sinuses, we have your frontal, ethmoid, sphenoid, and maxillary. Now that we have your pharynx, tonsils, and adenoids. These are important links in the chain of lymph nodes guarding the body from invasion by organisms entering the nose and the throat. Your pharynx or the throat functions as a passageway for the respiratory and digestive tracts. So your pharynx or your throat serves as the limiter, okay, or as a separator from the two tracts, the respiratory and digestive. Okay, so these are the functions of your pharynx, tonsils, and adenoids. We also have your larynx. It is also known as the voice box. The major function is vocalization. It protects the lower airway from foreign substances and facilitating coughing. So it is also referred as the watchdog of the lungs. So that means your larynx serves as a guard on the gate between the upper respiratory tract and the lower respiratory tract. Okay, so they are the ones, or the larynx is the one who is responsible for filtering all the foreign bodies so that it would not enter into the lungs. We also have the trachea, and it serves as the passage between the larynx and the right and left main stem bronchi to the lungs. Okay, so basically that is your trachea. It serves as a passageway, okay, going to the right and left stem bronchi, going to the lungs. We also have here the lower respiratory tract. It consists of the lungs, which contain the bronchial and alveolar structures needed for gas exchange. So as what I have mentioned, your lower respiratory tract is mainly the lungs. Okay, and inside the lungs we could see bronchial and alveolar structures there, which are mainly responsible for gas exchange. Now we have your functions of respiratory system. First, we have the oxygen transport. Oxygen is supplied to and carbon dioxide is removed from cells by way of circulating blood through the thin walls of the capillaries. The respiratory system functions also as a respirator or for respiration. After these tissue capillary exchanges, blood enters the systemic venous circulation and travels to the pulmonary circulation. Lastly, we have the ventilation. Ventilation requires movement of the walls of the thoracic cage and of its floor, the diaphragm. So basically, these three functions are for your respiratory system. We also have the mechanisms of ventilation. So these are physical factors that govern airflow in and out the lungs. So basically, this could influence the in and out of air from the lungs. Okay, so these physical factors can be air pressure variances, airway resistance, and compliance. For your air pressure variances, air flows from a region of higher pressure to a region of lower pressure. That means if the body detects that in a particular region there is a low concentration of oxygen or air, so the air from the higher concentration will transfer to that lower concentration region in order to balance the pressure within the regions. We also have airway resistance. Resistance is determined by the size of the airway through which the air is flowing. With increased resistance, greater than normal respiratory effort is required to achieve normal levels of ventilation. For example, if the patient has airway obstruction, so that means there is a greater or increased resistance. So the body will try its best to compensate with the lacking oxygen needed by the body. Thus, the respiratory system will make a greater than normal effort in order to compensate that lacking oxygen due to airway obstruction. We also have here compliance. It is the elasticity and expandability of the lungs and thoracic structures. Lungs with decreased compliance require greater than normal energy expenditure by the patient to achieve normal levels of ventilation. So that means if the patient has decreased elasticity and expandability of the lungs as well as the thoracic structures, so it would not guarantee a sufficient amount of oxygen going to the different parts of the body. So as a result, the respiratory system will exert too much effort, okay, in order to compensate those lacking oxygen. So it would spend a lot of energy from the body. So that is how your compliance factor could affect the ventilation mechanism. We also have the lung functions. So it reflects the mechanisms of ventilation, and it is viewed in terms of lung volumes and lung capacities. Okay? So for your lung volumes, these are categorized into tidal volume, or it is commonly abbreviated as VT or PV. It is the volume of air inhaled and exhaled with each breath. The tidal volume may not vary, even with severe disease. We also have your inspiratory reserve volume, or the IRV. It is the maximum volume of air that can be inhaled after a normal inhalation. Next, we have your expiratory reserve volume, or your ERV. It is the maximum volume of air that can be exhaled forcibly after a normal exhalation. Expiratory reserve volume is decreased with restrictive conditions such as obesity, ascites, and pregnancy. We also have your residual volume, or your RV. It is the volume of air remaining in the lungs after a maximum exhalation. Residual volume may be increased with obstructive disease. So these are the categories under your lung volumes. We have here now a lung capacities. Okay, lung capacities. So for your lung capacities, these are categorized into first, vital capacity, or VC. It is the maximum volume of air exhaled from the point of maximum inspiration. So we have here a formula. So vital capacity equals tidal volume plus inspiratory reserve volume plus your expiratory reserve volume. A decrease in vital capacity may be found in neuromuscular disease, generalized fatigue, atelectasis, pulmonary edema, COPD, and obesity. We also have your inspiratory capacity, or the IC. It is the maximum volume of air inhaled after normal expiration. So we have here a formula. IC equals TV plus IRV. A decrease in inspiratory capacity may indicate restrictive disease. It may also be decreased in obesity. We also have here your functional residual capacity, or your FRC. It is the volume of air remaining in the lungs after a normal expiration. So the formula is FRC is equals to ERV plus RV. Functional residual capacity may be increased with COPD and decreased in ARDS and obesity. Lastly, we have your total lung capacity, or the TLC. The volume of air in the lungs after a maximum inspiration. So we have here a formula. TLC equals PV plus IRV plus ERV plus RV. The total lung capacity may be decreased with restrictive disease such as atelectasis and pneumonia and increased in COPD. So these are the 4 categories under your lung capacities. Now let's discuss about pulmonary diffusion. It is the process by which oxygen and carbon dioxide are exchanged from areas of high concentration to areas of low concentration at the air-blood interface. So basically, it applies the principle of diffusion. So from higher concentration going to the low concentration. So it involves the oxygen and the carbon dioxide. We also have your pulmonary perfusion. It is the actual blood flow through the pulmonary vasculature. So this happens at the vascular level. So it involves the bloodstream capillaries inside the lungs. We also have the ventilation and perfusion balance and imbalance. Adequate gas exchange depends on an adequate ventilation or perfusion. So we can abbreviate ventilation as V and perfusion as Q. Okay? Ventilation and perfusion imbalance occurs as a result of inadequate ventilation, inadequate perfusion, or both. So meaning to say, if there is inadequate or imbalance between these two, ventilation and perfusion, or both, it could mean a problem. Okay? We have 4 possible VQ states in the lungs. First, we have the normal VQ ratio. We also have your low VQ ratio, shunt, high VQ ratio, dead space, and absence of VQ, or we call that a silent unit. Okay, let's discuss each. For your normal ventilation and perfusion ratio, a given amount of blood passes an alveolus and is matched with equal amount of gas. So that means the ratio is 1:1. So ventilation matches the Q. So we don't have a problem here. Okay, this is a normal finding. This is a normal proportion between your ventilation and perfusion. Now we have your low ventilation and perfusion ratio, or we call that shunt. Okay, so it is called a shunt producing disorders. When perfusion exceeds ventilation, a shunt exists. That means blood bypasses the alveoli without gas exchange occurring. So it is seen with obstruction of the distal airways such as pneumonia, atelectasis, tumor, and mucus plug. So the problem here in your low VQ ratio or the shunt is that blood does not go to the alveoli. Okay, that means if it bypasses the alveoli, that means gas exchange will not happen. So the oxygen and carbon dioxide would not be regulated or will not be exchanged, okay, in order to maintain the balance of these two elements. We also have your high VQ ratio, or we call that as dead space. When ventilation exceeds perfusion, dead space results. The alveoli do not have an adequate blood supply for gas exchange to occur. So variety of disorders such as pulmonary emboli, pulmonary infarction, and cardiogenic shock. So that means the problem in your high ventilation perfusion ratio is that there is insufficient blood supply in order for a gas exchange to happen. We also have your silent unit. In the absence of both ventilation and perfusion, or with limited ventilation and perfusion, a condition known as silent unit occurs. So the problem here is there is an absence of these two mechanisms. So it is seen with pneumothorax and severe acute respiratory distress syndrome, or your ARDS. Now let's proceed to your assessment, okay? Since we will be caring to our patient in terms of the respiratory conditions, it is very important that we should assess them comprehensively and correctly. So for your assessment, we have to first obtain the health history of the patient. So it includes, or it focuses on patients presenting problems and associated symptoms. And it includes also all aspects of patients' lives. Also the activities of daily living. The quality of life can be included, as well as the past health and social and family history. Now let's proceed to the common symptoms that our patient might experience in terms of the respiratory condition. We have here major signs and symptoms. First, dyspnea. We also have cough. Patient might experience sputum production, or the patient might produce sputum. Chest pain. Patient might have wheezing, hemoptysis. Okay, so these are the 6 major signs and symptoms that you should take note in assessing the respiratory condition of your patient. First, let's discuss about dyspnea. It is a subjective feeling of difficult or labored breathing, breathlessness, or shortness of breath. So please take note that we also have other terms such as tachypnea. It means that it is an abnormally rapid respirations. We also have your hypoxemia, which means low blood oxygen level. Also, we have your orthopnea. It is the inability to breathe easily, except in upright position. We also have cough. Okay, it is a reflex that protects the lungs from accumulation of secretions or the inhalation of foreign bodies. And it is considered as a diagnostic clue. So actually, the cough mechanism or the cough reflex can serve as a warning sign for us to know that the patient might have a respiratory condition. Okay? And it is also a mechanism of the body in order to get rid of accumulated secretions and inhaled foreign bodies. We also have your sputum production. The reaction of the lungs to any constantly recurring irritants and often results from persistent coughing. Okay, so that's your sputum production. We also have here chest pain. May be associated with pulmonary, cardiac, gastrointestinal, or musculoskeletal disease or anxiety. It may be dull, aching, and persistent, or sharp, stabbing, and intermittent. Patient might experience wheezing. It is a high-pitched musical sound heard mainly on expiration, so that is for asthma, or inspiration, that is for your bronchitis. It is a major finding in patients with bronchoconstrictions or airway narrowing. So if you detect or if you have noted wheezing from your patient, you would actually know that the patient is experiencing bronchoconstriction or airway narrowing. Lastly, we have your hemoptysis, the expectoration of blood from the respiratory tract. The onset is sudden or abrupt and intermittent or maybe continuous. So this is your hemoptysis. So basically, it's the expectoration of blood from your respiratory tract. Okay, So if you note these common or major signs and symptoms related to your respiratory system condition, you would know that the patient is experiencing some respiratory disease or illness.